so now in session 2, we will dive deeper into another focus, because now we really want to understand how can we source that medicine, right? So we just learned that mother's own milk is such a powerful therapeutic tool, but we really need to source this medicine with care. And to do so, perinatal teams depend on close collaboration with the mother. Unlocking and also maximizing her full milk-making capacity is really key, especially when lactation risk factors are present. And this is not only a clinical challenge, this is also a relational task for us as healthcare professionals. So in a nutshell, this session is about empowering perinatal teams to support mothers with lactation risk factors. And to do so, we need awareness of the many risk factors that can disrupt breastfeeding. We need to identify mothers early before the challenges escalate, and we need structured, evidence-based support to ensure that these mothers receive timely and efficient intervention. So to open up this very important session, I'm really delighted to welcome our next 2 speakers on stage. They will give a shared presentation. Please give a warm welcome to Professor Donna Geddes and Dr. Stuart Prosser from Australia. Professor Geddes is an internationally renowned expert for her groundbreaking research in human lactation and breastfeeding. And now she and Stuart would like to share a very exciting project they had together. Dr. Prosser is Director of the Obstetrics at Western Australia. And I'm excited to learn more about your project.
Thank you.
Thank you. So.
Take a seat, Stuart. Up second.
Okay.
So, Dr. Stuart Prosser is a GP obstetrician, anesthesiologist, which is hard to say when you're jet lagged, but a passionate advocate for breastfeeding. And when I first met him, I asked him why he wanted to do research, and he said he was tired of seeing mothers late with problems he couldn't fix. And he was just good at making them feel better. So he's making a huge impact with changes in his model of care. And one of those changes has been introducing evidence-based screening during pregnancy to identify women that are at risk of low production in particular. You can see on the slide that I've got up that there is another person in this team, Dr. Sharon Perella. She's a neonatal nurse, she's an LC, she's a PhD, and she's also passionate, and she works clinically with Stuart to implement these tools and develop them. So she's here with us in spirit, and I must also apologise that this talk will be given in Australian, so there is no translation available on the app. So why are we doing this? We're all working really hard to increase breastfeeding rates. And you can see in this red graph that we've only got exclusive breastfeeding rates globally sitting at around 48%. And we might reach the 50% target in 2025 if we're lucky. But the brief has been to aim for 70%. And you can see in the bar charts that only less than half our babies are feeding within an hour of birth, which is really sad, and only half of them are exclusively breastfeeding. We can see greater rates of breastfeeding, interestingly, out to 1 year of age and then diminishing at 2 years of age. So we have a problem. These increases in breastfeeding rates that you have seen since 2017 are illustrated in this bar graph. So these countries on the left are mainly low-income countries, and you can see in the 2017 scorecard, they were sitting well below 40%, and they've made the greatest increases in exclusive breastfeeding. But for over a century or even longer, the reasons women give up breastfeeding early is because their infant is perceived to not be satisfied for breast milk alone. They don't feel that they have enough milk, and we have largely ignored these women. So let's take a step back and look at what's essential to produce enough milk for our baby. We have breast development happening at critical periods in development, fetal, during puberty, and during pregnancy, when we get that proliferation of glandular tissue getting ready to synthesize milk. We don't know a lot about that process. We know more about dairy cows and mice than we do about women. We have some hints about genetics, and we largely ignore the fact that there are genetic mutations that affect milk production in women, such as zinc transporter mutations. Then the mother gives birth, and it's all on. Secretory activation begins, and that's a very short period where the breast activates milk synthesis in the 1 to 5 days after birth. Tight junctions close, milk composition changes, and it increases in its synthesis rate. And then in about 5 to 10 days after that, the literature shows that women can reach full production in 10 to 14 days. And we know that production at 2 weeks predicts production at 6 weeks. So we know from the literature there are risk factors. There are anatomical risk factors, breast surgery, nipple piercings that have been infected. There are metabolic issues that impact the mammary gland, diabetes, polycystic ovarian syndrome. There are psychosocial issues, of course, but they largely mediate the production of milk. And breastfeeding is largely ignored, and obstetric care is typically limited to the waist down, except in Stuart's clinic. And breastfeeding intention is recorded but not really discussed. We were talking about caesarean sections at lunch, and in our recent study of 112 women, they indicated that only 20% were attending antenatal breastfeeding education. So our mothers are not being educated about breastfeeding in pregnancy. So we thought we'd be talking about the first tool, but it's really a trio of tools. And we're looking at risk factors early in gestation, around about 26 weeks, 28 weeks in the clinic. We look at age, breast growth, BMI, GDM, PCOS, thyroid dysfunction, and the breast anatomy problems. The hormones involved in those metabolic processes impact the gland as well as the pregnancy. And then at around about 32 to 36 weeks is another late screening to look at the predictors of low milk production or reduced breastfeeding, including weight gain, late gestational hypertension, preeclampsia, and fetal growth restriction. And then we also obviously have an early postpartum screening tool as well. And we're collecting data on the outcome of all of the mothers that are screened at Stuart's clinic. Now, just brushing on breast surgery, breast reductions make a huge impact on the mammary gland. There's aggressive removal of glandular tissue in the inferior portion of the breast. That's where most of the glandular tissue is. And so it's reshaped. And then there's repositioning of the areola and the nipple. If you cut the ducts, they don't rejoin. So you're limited to the glandular tissue that is exiting via the ducts into the nipple. So we have impaired milk flow for those mothers. Breast augmentations, we're beginning to wonder how many of these mothers had hyperplasia, and that was the reason for their augmentation. And we know that the ducts are really compressible. So if we have engorgement, you can compress those ducts and limit flow out of the breast. I mentioned the endocrine disorders. We know that thyroid hormones affect STAT3. That's a genetic pathway that regulates death of the mammary cells, and also prolactin. We all know prolactin is instrumental in milk production. PCOS, we have high androgens that impact milk production. Insulin with diabetes, insulin's critical for milk production. And with obesity, we're now showing higher estrogen levels in the milk that may be coming from the local adipose tissue in the breast, putting the brakes on milk production. So we have a list of these things that are put into a screening tool. And you can see it's on one page. That was really important and really hard to get done. We had to eliminate people's urge to record everything and tick a box instead. You will see that every risk factor has a colour in the fine print there. And that's a traffic light system. Basically, if you tick a risk factor, you're at risk. And we decide by the traffic light system how to approach the conversation and what to recommend in pregnancy. So the red ones, we strongly encourage the breastfeeding workshop, which is evidence-based. It's not like your usual workshop. And we also recommend one-on-one antenatal lactation consultation to talk about red flags. What might happen? What would you do if this happened? Because as somebody aptly said, delivering information after birth is not the right time to be telling women what to do. Anytime, probably. That's right. So, and if you're orange, we do recommend the workshop and an antenatal consultation if she would like one. And if you're green, you get the workshop anyway. So what's been happening so far with breast development? We've been doing nothing, absolutely nothing. With the screening tools, we now use it to examine the breast, look at the breast, because what do you know, hyperplasia is quite a common thing. We educate, inform and prepare the mothers. It's important they know where to get the resources and source them now in pregnancy. So the lactation screening tool was implemented in the clinic at 28 weeks with the midwife. She talks to them about breastfeeding, expectations and education. And if she's at risk, we talk about frequent breast emptying within 2 hours of birth, and we get this conversation going early. At the late screening, this is another touch point for a conversation, and if we think the mother might need a pump, we flag that and make sure she has access to it and knows how to use it. We do also ask the mothers what their goals are, what they want to do with the breastfeeding. And you can see by the circle on the right that only 45% of mothers are planning to feed to somewhere between 6 and 12 months, and only 21% beyond that, with 20% only feeding for about 6 months. This is an important point to talk about and to respect and have conversations around. So what do we find when we audited all of the records after screening for these mothers for risk factors? You can see, consistent with population averages, in Perth we don't like to underdeliver. We've got over 40% of our mothers overweight or obese, and we know that's not conducive to good milk productions. You can see our incidence of GDM is up around 12%, and PCOS around about 8%, and thyroid disease at around about 7%. You can see that we don't have a lot of women in the clinic that have had reductions or augmentations, but you can see concerningly that nearly 50% have any risk factor, and around about 30% have more than two risk factors or more. You'll see we've got breast growth in here. That lack of breast growth recorded at over 20%. We can't ignore that. When you ask the question if a mother's breast has grown and she goes, oh, a little bit, that's a hard no. If she says, my husband thinks they grew a little bit, that's a hard no. Definitely a hard no. Did your breasts change during pregnancy? Not really. Hard no. We just had a mother come in for a breast ultrasound, and I asked her if her breasts had grown, and she said, well, the band went up a size and your ribs expand during pregnancy. A hard no. She was trying to explain to me that maybe they had. So it's important what you ask the mothers, right? In our mothers that had no risk factors, 77% of mothers fully breastfed, and we tend to use fully breastfeeding because we've found an increase in the use of formula in hospitals, unfortunately, that many women do go on to fully breastfeed after that. You can see across that line that 50%, only just over 50% of all of the women with those risk factors are fully breastfeeding. You can flip a coin and guess which ones are going to make it or not, which is another thing that we're looking at right now as well. So there really is a risk of not fully breastfeeding for these women. If we look at the relative risk between the group without any issues and those with it, if you have one risk factor, you're 70% more likely not to fully breastfeed. If you have a high BMI, you're 70% more likely not to be fully breastfeeding at 6 to 8 weeks. If you have GDM, you get the gist of this, 70% more likely not to fully breastfeed. But if you are overweight and have GDM, the compounding becomes obvious and you're twice as likely not to fully breastfeed. And the same goes for high BMI and PCOS. Twice as likely not to be fully breastfeeding. And I have to say, this is in an environment where there's quite a lot of support at the clinic, where everybody is trained in this. So this has been published in the Journal of Midwifery and Women's Health and is freely available. We're busily being asked to implement this in local hospitals and talking about adapting it in the NICU as well with the director there. And aspects have already been integrated into the WA pregnancy handheld record. So that's a book that every woman who gives birth in West Australia gets. And so in the breastfeeding section, there is some talk of risk there. So I've done my part now, so I'm going to hand it over to Stuart to tell you about how he implemented the tool.
So thanks, Donna. I get to talk about how easy the tool is to use. So one of the key things that I wanted to have when I introduced it was it had to be easy to use, it had to be one page, there had to not be a score. I find scores are open to interpretation, and it either has to be they have a risk factor or they don't. And that's why the screening tool is, we've chosen to have a very simplistic approach. The other thing is that it's really easy to implement. So we wanted to make sure that everyone in our team felt comfortable utilising it. Therefore, you wouldn't have the normal barrier, which was either it's too long, it's too complex, it's too hard. One of the big things that I want to emphasise on what Donna talked about is that one of the key things that we're using the screening tool for is that it actually starts a conversation. So as part of you doing the screening tool and talking about risk factors, you're actually talking about what the patient's perception is about their feeding journey, what their intentions are regarding their feeding journey, and it's an ability to actually sometimes redirect some myths that have developed, but it's also an opportunity to provide them with support. I think one of the things that's really important for all aspects of care we deliver is about involving the patients in the decision making, but also setting expectations. So what they're happy for, what they're trying to achieve. And that will come more evident in one of the cases I demonstrate to you shortly. And most importantly is that the majority of women find the tool really easy. They really find it an easy tool to answer. They don't find it confrontational, and it's been really well accepted. So the first case is one of our lovely patients who's now had 2 babies with us. When she did her screening at 26 weeks, she had a pre-pregnancy BMI of 27. She also had a history of PCOS. Her initial diabetes screen was negative, but unfortunately on her second screening tool, she ended up having diabetes. Her pregnancy, so automatically she comes into the amber group. She has 2 risk factors. She has the BMI of being above 27 and she has a GDM on diet. So she was offered education and a one-on-one class, which she accepted. I think one of the hardest things to manage for this patient was that she came into this journey with an expectation that she wanted to exclusively breastfeed. And one of the things she found hardest, and one of the things that was most beneficial about the lactation consultation was about helping her come to an expectation and a plan that actually was not exclusively breastfeeding. She didn't develop any growth issues during pregnancy, definitely no blood pressure, so she had no issues when we looked at her again at 36 weeks. So her late screening tool there was no subsequent increase in risk factors. Again, we talked about making sure she had access to breast pump. She actually enrolled in one of our GDM studies, and so she was given a set of scales to do pre and post feed weights and also a pump. And she ended up having a non-elective cesarean section for failure to progress at about 4 centimeters. There was no fetal distress. She didn't have excessive bleeding. She had a plan to have skin to skin, which we did. She had a feed within the first hour, and she was using pumping within the first 72 hours to optimize her milk supply. Her feeding plan was, the whole design was for it to be manageable and attainable. And she had a 24-hour milk production of 351 mils at 3 weeks and 454 at 3 months. She managed to breastfeed for 5 months. She was incredibly happy with the outcome, even though she was supplementing. So let's fast forward 2 years, and she's pregnant again. She's coming to see us. She's actually been very healthy. She wanted to do everything possible. She was determined this time not to get diabetes, but unfortunately she got diabetes again. One of the most key points about her antenatal consultation on this occasion was, and I'm not sure what you call it in your country, but in Australia we refer to it as a triple feeding of death, which is where you're pumping, you're feeding, then using formula. And the first thing that this patient said to us was, I can't do that. I have a toddler. That is not something that I can achieve, but I want to breastfeed as much as I can. And so a lot of this consultation was, in regards to the antenatal consultation, was talking about a sustainable breastfeeding plan that worked for her. And so she was determined that she wanted to breastfeed this time, and she ended up deciding that she was going to express 4 times a day around when she had the support of her partner. And she had an elective Caesar. We optimized. She also utilized a wearable pump this time, but also was expressing 4 times a day, and she produced more milk. So first time she pumped 8 times a day, second time she pumped 4, and the second time she got significantly more amounts of milk. The other thing that's important to note is she ended up breastfeeding for 18 months on the second occasion. So one of the things that we did find when we were doing it is that the initial screening tool was awesome. It was really good at identifying those at risk, but we were missing them. We kept having these patients where we were saying, well, we can't work out, well, the screening tool wasn't helping us identify those that were at risk of having low milk supply that had developed subsequent to the screening tool. And just to note, in your local service, as a screening tool, we do 26 weeks because that works with our time frame. We have a long planning appointment of 80 minutes at that time, and so it logically fits that that's when we do the breastfeeding screening. But really, you can do the breastfeeding screening anytime from 13 weeks. So whenever fits in with your local service, you could do it from 13 weeks up until 30 weeks, whatever fits in with your local service. We just choose that time because that fits for us. But there are things that happen late in pregnancy that we know are risk factors for low milk supply. So you're looking at that late onset diabetes. You're looking at that high gestational weight gain, the gestational hypertension, in particular the preeclamptics, the growth restriction, and the postpartum hemorrhage. So we started, well, postpartum hemorrhage we can't see till after birth, but the other factors we can look at 36 weeks, they're often becoming apparent. And so we introduced a late screening tool looking specifically at these risk factors. And the thing that I'd like to highlight is that what we did find is that, yes, blood pressure was a risk factor, but it was more the preeclamptics that were the problem. They were the ones that tended to have more issues with feeding. The ones that we definitely found were the risk were the growth restricted. So the growth restricted babies had a very high incidence of not being able to, of having low milk supply and not being able to fully breastfeed. The PPHs are really interesting, is that what we tended to find is that in the end is that they often had a delay in lactogenesis, but in the end they still achieved a high rate of exclusively breastfeeding. So our next patient, can't see it because this baby's about 3 months at this stage, but this baby was a beautiful 4.8 kilograms at birth. But going through them, each of them, at 28 weeks, there's no risk factors. Normal BMI, no diabetes, everything perfect. She attended the antenatal breastfeeding class, didn't attend a one-on-one antenatal consult because there was no indication to. 36 weeks, again, no risk factors. Perfectly normal pregnancy. She went on to a vaginal delivery with a PPH. Unfortunately, the baby did end up having a little bit of time in the nursery. Didn't drop its blood sugars, but did end up being treated for IV antibiotics. Because the baby was a beautiful 4.8 kilograms, is that on discharge, and especially because there was a delay in lactogenesis associated with PPH, there was breastfeeding with top-ups. She did manage to get to fully breastfeeding by about 8 to 10 days. Her milk production was originally a little bit on the lower slide, probably contributed by the fact that the baby was a little bit of a terrible feeder. I did hear a theory yesterday that it was all boys, which is probably the case in this one. But there was a combination of a little bit of separation initially, the PPH, a little bit of slow milk coming in, terrible feeder. But she ended up continuing to express and ended up achieving a full milk supply by 6 weeks and ended up breastfeeding for 18 months. The last example that I'll give you was a patient that had small gestational age and postpartum preeclampsia. So at 28 weeks, no risk factors, normal BMI, no problems in the pregnancy, attended the antenatal breastfeeding class. At 36 weeks, by that stage, we developed that there was some slowing of the growth. There was also starting to become some issues with the Dopplers. The fluid was starting to go down. At 37 weeks, the baby was 2.9 kilograms. Abnormal Dopplers were developing. The plan was made for delivery. An induction was undertaken, which unfortunately led to a non-elective Caesar. She also developed postpartum preeclampsia up to 180 on 100 and was discharged on labetalol. She was breastfeeding at discharge, but the baby continued to have issues. There was a lot of cluster feeding. Mum was quite fatigued and teary. Didn't see us until about day 9, unfortunately. She was commenced on artificial top-ups at that stage because the baby was only just above birth weight at day 13. She never achieved, we missed a window of opportunity on a patient that was at risk. But still was mixed feeding and ended up mixed feeding to about 4 months. So does antenatal screening improve breastfeeding rates? Well, clearly the answer is yes. So what we've found is that we've now got over 500 patients. There's probably more than that. So we're continually looking at our data. And what we can see is in the orange group is within our clinic, the diabetics. The dark blue is the non-diabetics within our clinic. And then the light blue at the end is what Australia is tending to do. What you can find from that is that we do a really good job of initiating at 7 days, but importantly, we do a really good job of maintaining breastfeeding rates out to 3 months. The diabetics are really challenging. I'm not sure that we can do better than 80% at 3 months because there are a big group of that have very, very low milk supplies. And a lot of the patients will come to us at 6 weeks and say, I've done it for 6 weeks. You asked me to do 6 weeks. I can't do any longer. I can't continue to express. It's not manageable around being a mum of a newborn. And so, okay, sorry, I'll wind it up. But I think that overall, our success rates are really high, and hopefully they'll continue to improve. So just highlighting again the high level of breastfeeding rates we get within the clinic. So what are the golden drops? So screening for lactation is super important. Identifying risks, having conversations allowed much better outcomes for our patients. One of the things that I really like about the screening tool is the fact that it is a conversation. It allows us to set realistic expectations, but also to develop a feeding plan in conjunction with the patient that works for them. And the most important thing, and I think I originally came to Donna saying, please remember I've got a really low attention span and it needs to be really short and easy to use. And so I think one of the things that's great about the screening tool that we use is that it's really simple. Everybody can use it, and it would take very little effort for every single person in this room to implement it within their own service. Is that it?
Thank you both for this inspiring talk. This is really a call to action for all of us in perinatal care because, yeah, obviously we need a systematic antenatal breastfeeding screening to improve outcomes for mothers, babies, and their families, right? So with this, I would like to introduce our next speaker. Please give a warm welcome to Professor Paula Meyer. You could come to stage if you wish. Professor Paula Meyer is from Rush University Medical Center in Chicago, joining us from the US today. And she's a global expert in breastfeeding and lactation. She has over 5 decades of experience. I was not even born then. And has shaped both clinical practice and policy in the field. So Paula, I'm really glad that you're with us. The stage is yours.
Thank you. So this was actually a great presentation to follow because if we've identified risk, what is the next stage? What do we do to try to mitigate that and to manage it? So I'm going to be focusing on secretory activation and how it informs best clinical practice. My disclosures are listed here. I'm not going to go through them. If anyone's interested, I can certainly share them, but in the interest of time, I'm not going to do so. So my talk is really consumed within the concept of early, unplanned cessation of lactation, in both term, healthy dyads and at-risk dyads. And to that end, I want to make everyone aware that many of the data sources I'm going to be referring to today are individual papers in this issue of Breastfeeding Medicine that Dr. Leslie Parker and I co-edited. That was from July 2025. And we're very grateful, obviously, for the funding for the individual papers that you can see in this edition. But we're especially grateful because Medela actually funded the open access for us. So you can click on the QR code and everything in this journal is open access, free of charge to you for referring. So why target the first month post-birth? Because within the first month post-birth are probably the most complex sequences of lactation that exist. So the complex biology of secretory activation, or as we think of it, lactogenesis to the milk coming in, followed by coming to volume, which actually we refer to as achieving 500 milliliters of pumped mother's own milk by day of life 14. Secretory activation is a largely hormonal-driven process, and when a mother achieves secretory activation and goes on to working towards coming to volume, there's a complete change in the way that lactation processes are regulated, which I will go through. So this is a very complicated scenario, but unfortunately, it's essential. Secretory activation is essential for continued lactation, And coming to volume or reaching this 500 milliliters by day of life 14, if you are a mother of a premature baby in the NICU, is the primary predictor, and it's a strong predictor, of still providing your baby with milk at the time of NICU discharge. Well, one of the things I wanted to work on is to replace this whole idea of support. I so often hear mothers need more support. I edit papers or review papers for scientific journals, and they end with, this population needs more support. But nobody defines what that is. Is it an extra visit from a lactation consultant? Is it peer counselors? Is it more time that you have to have your baby in skin-to-skin care? So what I really want to do after my 5 decades of working is to focus on replacing this generic term of extra support with specific evidence-based interventions and guidelines that can be translated into clinical practice. So most of our interventions, as we think of them today, have been behavioral and motivational. So my focus today is going to be on the biology of secretory activation and coming to volume, because regardless of the problem, and Donna and the previous speakers just mentioned this, it's mediated biologically. It can be stress, it can be infrequent pumping because you're stressed, but it's mediated biologically. So we have to understand the biology of these processes. So the first thing I want to do is just to define a couple of the terms I've shared with you and show you the data that inform them. I think everybody has heard that secretory activation has to be achieved for continued lactation. But to my knowledge, there really aren't good data about this, especially in mothers of preterm infants who are breast pump dependent. So one of our colleagues that we've worked with on the special issue is a statistician, Dr. Shunlin Pai, who actually modeled the achievement and the lack of achievement of secretory activation using sodium values. So this sodium in blue is mothers who achieved secretory activation, and these are mothers who did not. This is postpartum day going from 0 to 14. And the point that I want to make, out of 176 mothers, the mothers who did not achieve secretory activation did not go on to produce milk. So I think that this is a very strong set of data to document what we've heard of anecdotally. And then the second point that I want to make about achievement to coming to volume involves the upregulation of paracellular, or the upregulation of autocrine and pericrine pathways, or the milk-making apparatus as we think of it. And it really involves this intricate interplay between what the breast does and what the removing entity does, whether that entity is the breast pump or the baby. Prior to the mother achieving secretory activation, the human infant sucks in a human-specific suckling stimulation that mimics the healthy full-term infant during the days that there's very limited milk available because secretory activation has not been achieved. And I worked with Medela engineers many years ago to develop and do a randomized trial with the initiation pattern in the Symphony breast pump so that it would mimic this specific suckling pattern so that mothers who did not have their own babies would have the ability to experience that stimulation because it's thought to be essential for the continued milk secretion. So if we look then at this optic, what we see is that the breast synthesizes and secretes milk. It's removed by the baby or the pump. And we always think about the fact that that assures adequate intake, okay? We think about milk removal as so the baby has it. But milk removal, especially, is critical to regulate lactation processes. So if the milk is not removed frequently, effectively, efficiently, and comfortably, then it can't go back to regulate continued milk production and secretion. So the feedback that it's not just about the breast producing it, but how it is removed and the type of stimulation is really critical to continued lactation. And this point was made nicely by Sarah Taylor this morning. is that one of the disconnects here is that we want mothers to make at least 500 milliliters of milk a day if they have a NICU baby, because the odds of going home still providing milk for your baby, if you make 500 milliliters of milk a day, the odds were 10 times higher. So it was the strongest predictor of all of the different things we put into that model of 415 mothers of very preterm infants. So that, I think, summarizes the evidence that you have to achieve secretory activation and what's involved with respect to achievement of coming to volume. Now, if we look at the trajectory, what happens over this 14-day period? Well, we've heard from several speakers, pre-birth, the mammary gland undergoes secretory differentiation, preparing to feed. So it doesn't produce milk at that period of time because that milk is held in check by circulating progesterone that is secreted by the placenta. So when the infant is born, the placenta is delivered. What we see then in a very short period of time, and if you look, this is looking at day 0 all the way through the first few postpartum days, and looking at concentrations of the hormones, what you see is that rapid fall in progesterone allows prolactin to begin to actually synthesize milk. Then we think of a mother achieving secretory activation or the milk coming in. Typically, we hear about this being day 2 or day 3. In all of our studies, as summarized in our special issue, the average time for a breast pump-dependent mother of a preterm infant when the mother delivered equal to or less than 34 weeks was between days 5 and 6. So basically, it was normal to have delayed secretory activation. The next thing that we saw was this upregulation of autocrine and paracrine pathways, which means milk has to be removed frequently, effectively, efficiently, and comfortably, so that we achieve this volume of 500 milliliters by day of life 14, and then that predicts receipt of mother's own milk at NICU discharge. What I want to share with you, and we'll come back to this is a critical period for breast pump-dependent mothers in the NICU. Because once they have achieved secretory activation, as we define it by sodium, over half of our mothers had a sodium that was inconsistent with secretory activation as they upregulated the autocrine and paracrine pathways. And what that meant was, if you want to think about it, we think they're there, they've established secretory activation, but then the structure in the mammary gland changes so that the mothers actually go back to producing less milk. And in our data, it's primarily a function of interrupted pumping over that period of time. So just because we get to secretory activation doesn't mean we're home free. We still have to monitor the mothers over that next, at least the 14 days. So what do we know? Well, we know that secretory activation is this one-time event, as I said. It's the delivery of the placenta that allows prolactin to begin to synthesize and to allow the breast to synthesize and secrete milk. Then secretory activation, as we think of the milk coming in, involves the upregulation of 4 transcellular pathways and the closure of 1 paracellular pathway throughout the breast. It's a primarily hormonal process, but our data have shown that it is affected by stimulation from the infant or from the pump. And these are 2 of the special issue papers that were in our Breastfeeding Medicine journal that we describe these in great detail. Well, those 4 transcellular pathways and the 1 paracellular pathway, because they secrete components into the milk that change over the course from birth to secretory activation, can actually be measured in the milk, and they're called milk biomarkers. So we can actually measure the process of secretory activation and whether or not it is achieved using these biomarkers. So quite simply, what we see is that if we look at this graph, birth, and then secretory activation, and then lactation, at the time of birth, and until a mother achieves secretory activation, the sodium and the protein are high. And the protein is high because, again, that's the high molecular weight bioactive proteins that work as a type of an immunization for the baby, if you will. On the other hand, lactose, citrate, and potassium are low, and then they gradually increase as we approach secretory activation. So those can all be measured, but the one I want to talk to you about that's simple and can be done point of care now is using mother's own milk sodium or sodium to potassium ratio. Both of these are measures of the paracellular pathway closure. They don't measure transcellular pathways. They measure paracellular pathways and have been used for decades primarily in animal work to begin with, and then subsequently in research that involved being able to determine when secretory activation had occurred. These were used a lot in studies to determine subclinical mastitis over the period of time when there was a lot of work on AIDS being transferred in breast milk. But nonetheless, it's not new. What's new is that they're now point of care, and they can be done simply and easily, and they can inform what you do with lactation care. So quite simply, if we start, this is the individual breast, the alveoli, okay? This is how it looks at birth, and this is secretory activation achievement. The main thing we're looking at, if you can see the pink brackets, those are the paracellular pathways. Until a mother achieves secretory activation, those are patent. And once secretory activation is achieved, those are fused. And at this point in time, what we have is really what's called the blood-breast barrier. That's why so many medications are safe with lactation, is because if they're large molecular weight, they can't permeate into the milk. But nonetheless, when these paracellular pathways are patent, which they are at birth until activation is achieved, what happens is the components between the mother's circulation and the milk product itself move back and forth across an osmotic gradient. So the one that we're really the most interested in really is lactose. And why is lactose important? Well, lactose is secreted only by the mammary gland. It's excreted as a milk component, but when the paracellular pathways are patent, it passes directly from the mammary gland into the maternal circulation, and it's excreted in the urine. That's a problem because lactose is the primary driver of milk volume. So when lactose escapes the gland, it's virtually impossible to have a good milk volume. So when lactose is escaping, what we see is a mother is not going to achieve secretory activation or certainly build a milk supply. However, what also happens that's not really of interest, but it's easy to measure, is as the lactose is escaping, the sodium in the maternal bloodstream crosses into the milk as a function of these open paracellular pathways. And the reason that it is of interest is because once those paracellular pathways close, lactose stays in the gland, catalyzes the milk supply, and sodium is secreted only by one of the transcellular pathways and no longer comes from the maternal circulation. So this is really functionally the basis for these biomarkers. Now, potassium comes into this because people say that sometimes potassium is a way of standardizing the sodium in the milk. And I wanted to just share this with this group as you move towards point of care, because potassium really is the sodium-potassium ratio is a very new addition to these biomarkers. It really came into being in 1994 as a study of subclinical mastitis. So our question all along, as has been that of many people, is do we really need sodium-potassium ratio? And why is that the point? Well, sodium is easily measured point of care with this electrode. It's a Horiba electrode. And there's also one for potassium. And the way that it works is you just put a drop of milk in the sensor and you get the sodium value. It's very easy to use. But the sodium-potassium ratio requires more milk. It requires another step, the purchase of another electrode, and then you have to hand calculate the actual ratio. So again, our marvelous statistician, Dr. Pei, looked at a data set that we had, blanking here, I think it was about 167 mothers and infants And we had paired milk sodium and sodium potassium ratio. So if you can think of it, the mothers in the study provided milk, and we measure both sodium and sodium potassium ratio. And what she did was to look at, okay, well, let's use both definitions of secretory activation. Let's use less than 16 millimoles with a sodium potassium ratio of 0.8. And then let's use this more general one, generous one, that's 20 and 1. And what she found, this is the first detectable day of secretory activation. And what we found is that by and large, the biomarkers agreed. And if they disagreed, they were off by 1 day. So this we concluded along with another several analyses. This paper is now under review, that we don't need potassium. So we can get rid of the purple electrode and just go with the yellow one. So these now are done point of care. They require just a milliliter sample. It's quick, it can be done each day. And our team has published a number of papers on this topic already. Our work has been mostly restricted to mothers of premature babies that are breast pump dependent. But we do have 2 papers in our special issue that were done with healthy full-term infants. So that the data that we've analyzed and the studies we've used these for have been primarily in NICU. What I can tell you with these is that they are simple to do. It takes a drop of milk. It's feasible to do them each day in the NICU because what you want is a trend. You don't want a snapshot. You want a video starting on day 1, 2, 3, 4, 5, so you can advise the mother. And the other thing I would mention, I'm going to go back here just quickly to this slide so you can see. Do you remember when I said that we would have mothers achieve secretory activation by sodium, but then they would reverse it? The sodium would go high again as they went from secretory activation into achievement of coming to volume. This is the same thing that's happening. Yes, the sodium is coming back into the milk, which is what we measure, but the reason it affects the milk supply is because the lactose is leaving the gland and going back into the maternal circulation. So I'm going to finish my, my presentation. I have a handful of slides still, but on what some of our most recent data have shown in using sodium as a measure of secretory activation. So the first thing I want to acknowledge, I don't feel like I'm promoting a product because as much as I would like Medela to make this product, so we all have it, they don't. So it's not available right now for purchase. But we worked with Medela engineers to create what we call a smart pump. So you'll all recognize the Symphony, but you may not recognize what we called our data logger, which is a little computer. So basically what happened is we removed the guesswork. No more maternal logs about when they pumped, how long they pumped, how many minutes they pumped. Everything is recorded electronically. If the mother's using the pump, it's recorded electronically and stored in the data logger as a part of that mother's ID. The other thing, though, that we developed, which our mothers absolutely love, so if you want to think, oh, it's too complicated, no, the mothers loved this. So what we have is a little app that goes in, was created for us for the project, and the mother using this little scale, which weighs to the nearest 1/10 of a gram, and is one that we have used in all of our other research only as an external device, also has the data embedded into this mother's file. So for each pumping that the mother provides, she records how much she got from the right breast and the left breast simply by putting the container here and weighing it. So this was our very first study. We enrolled 29 mothers of babies under 34 weeks, and we followed those mothers for the first 14 days. So what did we see? Well, the first thing I want to see, again, no reports with mothers telling us how many times a day they pumped and how much milk they got. Everything was electronic. What we found was that first analysis we did was a cluster analysis. And we identified what we called high intensity and low intensity pumpers. So in this graph, the red mothers, when we look at number of pumping sessions a day, are the high intensity pumpers. And these mothers typically had more than 4 pumpings a day. These were the low intensity pumpers. And with that in mind, what I want you to look at, this was total volume pumped over those first 14 days in milliliters. So we've got high intensity pumping affects milk volume, and high intensity pumping also allows for the sodium to decline more rapidly so that mothers achieve secretory activation. So this ability to automate and to use the sodium to diagnose has been absolutely game-changing for us. Now, the other couple of things out of this paper that I am going to share with you is each additional hour that the mothers spent pumping in that first 5 days. So in other words, not every day, but over the 5 days, each additional hour resulted in additional 1,278 milliliters of milk. So this period of time is a critical window for mothers to use the breast pump. As we said, at least that 5 times a day, and if they pump more, typically we see a dose response. The other thing that we did for this study was we did what is actually the precursor for the pumping pathways that we'll be doing the workshop on tomorrow, in that we standardized not just the breast pump type, but the breast pump use in the first maternity hospital stay that was 3 days, as well as doing it a second time once the mother achieves secretory activation. Because if you look at what the baby does and what the breast does and what you want the pump to do, the baby sucks completely differently once we have achieved secretory activation and there's milk. So we want the pump to do that. So you think, okay, well, how many times, if you're a lactation consultant, you check the latch? Okay, well, how many times, if you're helping a mom pump, do you make sure the pressures are right? Do you make sure the breast shield is correct? Do you make sure that the breast shield isn't pushed into the breast tissue? Those would be comparable to your going in and checking a latch, because those things are going to affect the milk that the mother removes. So our intent, as I said, is to replace success, to replace support with actionable items. One of those we'll do workshops for tomorrow. So those 2 time points coincide with my pumping pathway 1 and 2. So those are the ones to get the mother started, and it's a guideline of what should be discussed with the mothers, not just to standardize pumping, but breast pump use in a way that's evidence-based. Because so many of the things we don't standardize independently affect milk volume. So we need to standardize those to make sure the intervention is truly effective. So one of the other papers in our special issue was done by Dr. Tricia Johnson. And Dr. Johnson is an economist and was really looking at what kind of time on the part of the mother is involved in the way of like an opportunity cost. How much time do you have to invest in achieving coming to volume and secretory activation? But what I'm going to show you here, because all of our studies, no matter how many different cohorts, and then when we combine them into one big cohort, all of those studies have shown that once a mother achieves secretory activation, that at least half of the mothers reverse those paracellular pathway closures in the first 14 days. So what Dr. Johnson looked at, what were the pumping characteristics of the mothers who maintained secretory activation versus the ones who did not. And what we see is the yellow is mothers pumping at least 120 minutes a day. Green is the next one down, and then going down from there in colors. So the point I want to make is that it isn't just about getting to secretory activation. It's about continuing not just an intermittent day where you're pumping at a regular frequency, but it's about pumping that way throughout that period of time. And we have many examples of mothers that fell short, and it wasn't because they didn't want to pump. It was because they were sick, they went to the doctor, and instead of pumping 8 times that day or 6 times, they pumped twice because they were in a doctor's office all day. Which really comes to the last couple of slides I want to share with you. And the previous presentation talked about maternal risk. Our mothers in our studies who deliver babies at 34 weeks or less have an average of 3 comorbidities of pregnancy. So we were very interested with this large data set. We had 143 for our special issue. We now have 176, and we're working on even more modeling. But what we looked at was the comorbidities of pregnancy. And I'm not going into all of the mechanisms, but the big ones that impact our mothers in the NICU are high BMI, and we use 27 and over, or I'm sorry, 27 and over and under 27 as a cutoff. The comorbidities increase the likelihood of operative delivery. So in our mothers, we don't know, is it the operative delivery and the therapeutics to treat the operative delivery, or is it the underlying issue that resulted in the operative delivery? And I think the point I want to make about this is that what appears as a delayed or an impaired secretory activation could very well be a problem that was secretory differentiation. And I think the previous team brought this up so nicely, the big one being the growth of the mammary tissue under conditions of inflammation, such as we talked about with high BMI. But we modeled this, and this is my final slide, so I want to spend a minute with this. We modeled overweight, obesity, hypertensive disorders of pregnancy, and diabetes in our cohort of 148 mothers. So in these mothers, we had pumped milk volume, we had pumping frequency, and we had sodium measures all the way through the first 14 days of life to be able to do these analyses. So what was interesting is that pumping frequency predicted everything. So the more you pump, the more milk you get, which I think is pretty standard. But the mothers that were overweight and obese, what happened was the obesity moderated that relationship. And simply what that meant was those were mothers that could pump an equal number of times, but still have a lack of achievement of secretory activation, less pumped milk volume, and lack of achievement of coming to volume. So in other words, it wasn't about pumping more, it was just that the obesity got in the way. They just weren't able to capitalize on what the pumping should do. We saw the same thing with diabetes, and I think what's interesting is both of those are metabolic diseases, and we saw that maternal diabetes as well was a moderator of the relationship between pumping and achievement of coming to volume. But the one that was really interesting, which I want to leave you with, is hypertensive disorders of pregnancy, because it was the opposite. Of all the morbidities, hypertensive disorder of pregnancy independently predicted a lack of secretory activation, delayed secretory activation, as well as less pumped milk. But when we looked at this, we found that that relationship between hypertensive disorders of pregnancy and the milk volume and these different outcomes was actually mediated by the breast pump. So in other words, part of the reason those mothers had less milk wasn't just the disease. It was because these are mothers without hypertensive disorders of pregnancy and their pumping frequency over that period of time per day. And these are the mothers with hypertensive disorders of pregnancy. And we found the same thing, interestingly, in this cohort. By the time of coming to volume, those mothers had caught up, but it was just this initial delay. So this is a lack of pumping on the part of these mothers, and it makes sense. They are so sick, we're reluctant to go in and have someone help them pump. But I think this, again, is something modifiable. So I'm not going to read through the summary. I've run out of my time. I do have a lot more data I'd love to share with you, but I just want to emphasize that the first 14 days postpartum is such a critical window, and the sodium probes that are quick, simple, easy to use are such a wonderful tool to begin to replace this idea of support that we don't quite know what it means. And we'll be doing more and more with the modeling of these morbidities as we move into our work in this space. So thank you so much.
Thank you so much, Professor Meyer, for your wonderful presentation. You really helped to uncover some of the secrets of secretory activation. Yeah, I think it's really amazing to see that now with the help of biomarkers like sodium, we can actually monitor what's happening in the breast in real time. I think that's nothing short of revolutionary. So now I would like to welcome our next speaker, Professor Diane Spatz, joining us from the United States today. A warm welcome, please, for Diane. Professor Spatz is a professor of perinatal nursing and nutrition at the University of Pennsylvania and a leading nurse scientist in lactation at the Children's Hospital of Pennsylvania, where she also founded the CHOP Mother's Milk Bank. Professor Spatz has helped shape clinical guidelines for major organizations and serves on key national and global task force. And her Spatz 10-step model has gone around the world and is implemented in many NICU around the globe. So please give a warm welcome again to Diane. We're looking forward to your talk.
All right, great. I'm so excited to be here. Thank you so much for the invitation to be here with you at the Symposium European edition. This talk is perfect to follow our previous two talks because I will bring some of the concepts brought up in these previous talks and kind of build them into then what is the ultimate way that we manage these families to help them achieve their breastfeeding outcomes. So I always like to give grounding to where we are from. So I am from Philadelphia, which if you haven't been to my beautiful city, it is the birthplace of the United States. I know the US isn't the best place to visit right now, but maybe in the future you can come see me. And we are, some people call the city of brotherly love, but I would call it the city of motherly love because we embrace lactation in our city. And I live right over by that little boardwalk area. So if you've met me before, you know that I have two jobs, one at Penn Nursing and one at Children's Hospital Philadelphia. One of the things I'm very proud of is the ability to teach and mentor students across the curriculum from BSN to PhD. I came to Children's Hospital of Philadelphia for my clinical role because I care about surgical babies. And back in 2001, no one was talking about surgical babies. There were no publications at all, and they were ignored in the literature. And so I really care about babies like Charlotte. And I had the opportunity to meet her family prenatally. So since 2001, we've actually been doing prenatal lactation risk assessment at CHOP and doing that proactive management with our families in the Center for Fetal Diagnosis and Treatment. I love human milk because it doesn't only save babies' lives, but it can also transform the entire family, okay? So this is baby Charlotte and her mother today. Charlotte is now a teenager. She has passed every test with flying colors. She is off the charts in her IQ, right? And the only way you would know that she had an omphalocele that had 8 surgeries is that she doesn't have a belly button. Okay, that's it. And she talks about how human milk saved her life. Her mother, because of her experience at CHOP and having extra milk for her baby, donated milk to a milk bank before we were our own milk bank. And she stayed active with me in talking about the importance of human milk and became the executive director of the Human Milk Banking Association of North America. Human milk transforms babies' lives. Lactation can transform a family's life. We do have models that exist to change practice. And some of the challenge is that people just don't take the time to use those models. So we have clinical practice guidelines. We have methods in order to improve or change hospital practices, but we have to embrace them. And so Donnie mentioned about my 10-step model, which goes beyond just the traditional BFHI, which focuses on what to do when we have a healthy situation. But we've heard repeatedly today that that is not what most families are experiencing. Most people are experiencing one or more complications, whether their baby's sick or whether they have lactation risk factors. And so Many countries around the world, and actually all the continents except Antarctica, have had hospitals who've implemented this. When I first published 20 years ago, I really was thinking about it just from a perspective of sick babies. But really, if every family doesn't make an informed feeding choice, and if every family doesn't establish milk supply, which we heard just from Dr. Meyer, right, we're not going to have long-term breastfeeding families. And so I want to bring up the international work group that Medela so graciously supported that was really working with midwives across the globe to develop a call to action and clinical pathway to protect milk supply. So I am not a midwife. I'm a perinatal nurse by background, but I've always spent my whole career hanging out with midwives. They are my friends. So we had representation from across the globe. We met many times to really look at the literature and to talk about what we as healthcare providers can do to protect milk supply and really have clinicians have a much higher awareness of risk factors and then how to manage those risk factors. So these publications are available open access. And now we're going to come to our first polling question. And that question is, how many of you presently conduct a prenatal lactation risk assessment and then also inform the parents of their risk factors? And I ask it in this way because sometimes when I speak about proactive management and identification of prenatal risk factors, I have had lactation consultants say to me, well, I don't want to tell the mother she has risk factors because then I will just worry her. Have you ever heard that? Right. So do we have the answer to the poll? It's coming, maybe. Yes, it's coming. We can dance, we can sing, we can stretch. I'm the only speaker who put polling questions into my talk. That was maybe a mistake, but I was advised to do so. I can go forward? It won't. Okay. Well, hopefully people are going to start doing prenatal risk assessment. Anyhow, we've already heard about all of these different risk factors from our prior two talks. I think one of the things that's really critical to understand is that most of you probably have people who have 1, 2, 3, 4, 5, 6 risk factors. I don't ever meet parents that have 0 risk factors, right? And so having that sense of urgency to really help people understand that we can proactively manage their risk and we can help them to be able to achieve secretory activation and coming to volume, whether or not their baby is sick or healthy. So Donna mentioned parents who might not be able to have a complete milk supply, right? And this article, which is published, came from one of our pediatric nurses because she came to me and said, I'm really frustrated that in a pediatric office, I have a baby present with 17% weight loss, and then I have the parent take off their top, and I find out that they've had breast surgery or they have abnormal breast tissue development. Why are these things not getting identified antenatally? And interestingly, in a systematic review that was published about glandular hypoplasia, they found 40 out of 42 women only provided milk for less than 1 month, so they didn't come to volume. There was a case that was not included in that systematic review, surprisingly, and it was a publication where we discussed a parent who had this condition but optimized her milk supply with a pump, with medication, and by having a scale to do pre and post weights. And she was able to produce 400 mLs of milk a day for her baby and provide milk for 6 months. Not exclusive, but she was very happy that she had that opportunity. Breast surgery, Dr. Geddes talked about it. I recently published an article about breast reduction surgery. We see a lot of breast reduction surgery in the US. And one of the big problems with the literature about breast reduction is it's published by plastic surgeons in plastic surgery journals. And they're not looking at milk production capacity, right? And so this just happened to me right before I came over to Portugal. I had a pediatric dental fellow come up to me when I was lecturing for them, and she said, well, I had breast reduction, and the surgeon told me I'd have a 60% chance of breastfeeding without surgery and a 50% chance if I've had breast reduction surgery. That's what she was told. Where did that plastic surgeon get that from, right? It's not research-based. So giving people evidence before they give birth about optimizing their milk-making capacity. And if they've had the type of surgery where they've had their whole areola removed and reattached, their milk-making capacity might be minimal. I have a personal friend who had this, 100 mLs a day. That's all she could make, right? So augmentation. Again, Dr. Geddes mentioned this. What was the reason for augmentation? Was it because they just wanted bigger, fuller breasts? Or did they really have glandular hypoplasia? And that's why they had the surgery. So how do we help them optimize whatever milk they can make? What about breast cancer? I recently worked with a woman who breastfed her first child exclusively. Long breastfeeding journey. Got diagnosed with cancer, had treatment, got pregnant. She's like, am I going to be able to breastfeed my baby? She was able to provide 100% human milk for her child, exclusively breastfed with just one breast, right? But we have to give counseling prenatally. We have all the parents at risk for delay in secretory activation. I don't need to re-mention them. We've had them talked about. But we want to have these proactive strategies, right? How are we going to help people with risk proactively manage their lactation journey? So here's my polling question too, which is clearly not going to work, at least in person. But you could raise your hand if you're in person, and everyone online. Oh, it's going to work? He's fixing it. Yes. Okay, good. Does your facility have a policy for antenatal milk expression? And then for storing this milk when the parent comes in? So it's really two questions, but you just answer yes or no to both of them. One question. Okay, and this has come up a lot because we're seeing parents bringing in milk, and some hospitals are telling them they can't, or they won't feed it to the baby, or they tell the parent that they have to take it back home, okay? But people are seeing antenatal milk expression on TikTok, so they're doing it, right? So, vote now. Ooh, look at that, half and half, all right. So clearly something that we are seeing in clinical practice, right? And is gonna be a continued challenge for us, especially because people are going to social media to get breastfeeding information. Donna said 20% of her cesarean moms, that was it. That's all who had breastfeeding education prenatally. Okay, can we go back to my slides now? Yes, okay. Antenatal milk expression. Dr. Geddes was part of this work with my doctoral student, Nina Gentriel. So this work was done at the Center for Fetal Diagnosis and Treatment at Children's Hospital of Philadelphia. We specifically used this population because all of the parents were going to have sick babies and all the parents were going to be pump dependent. So it would be easy for us to measure the milk accurately and measure the lactation biomarkers accurately, right? So we enrolled the women when they were 36 weeks gestation and taught them about antenatal milk expression, which then they commenced at 37 weeks. We recommended them to do it 2 times a day, hand expression, and we very accurately measured how much they could collect. They collected their milk with a little 1 ml oral syringe, They took a photograph of it, and then they brought it in with us so we could actually view it and validate the amounts. And what we found was that most every person was able to collect or harvest some milk, but it was very small amounts. And so if they're learning about antenatal milk expression on TikTok, and they're thinking that they're going to get 2 ounces of milk, right? This is a big problem, right? So we need appropriate anticipatory guidance, because the worst thing would be if we told parents to do this, they tried it and they didn't get anything out. And what are they going to think then? Well, my breast must be broken, and I'm not going to be able to breastfeed my baby. So post-birth, Nina used the sodium probe that you heard about, okay? So we used a sodium probe to check the sodium at point of care, and then Nina also got to travel to University of Western Australia to analyze the lactose biomarkers. What we found is by doing AME, people didn't have earlier secretory activation. Donna and I were not at all surprised about this. But we hear and we consistently see it reported in the literature that people believe that if you do AME, you're going to get milk earlier. It doesn't happen. The baby has to come out, the placenta has to come out, right? We need those two things to happen first. Now, interestingly, our parents did have a delay in secretory activation. Not surprising based on what we heard from the first two presentations. They did actually all come to volume. Our mothers are highly compliant with pumping at our institution, pumping 7 times a day, okay, pumping 7 times a day. So they did come to volume, but it took longer than just 3 to 5 days, okay? So our post-birth factors. We haven't talked too much about these, but you're familiar with them, right? Maternal-infant separation, having that cesarean birth, that baby who goes to the NICU, that baby who gets formula supplementation, okay? All right, we're gonna see. Question number 3, does it work? Are you currently tracking your time to first breastfeeding and or pumping sessions, along with that number of pumps per day? Okay, and then do you report that back? Okay, so you actually, to say yes, need to answer yes to all of those questions, right? And you know, not everyone has that little smart pump that Paula has, right? But that's what I'm talking about. If we all had the smart pump, it would be great. But most of us don't have the smart pump, which means how do we give data to people to show that they're doing a good job? Right, and when we opened our special delivery unit in 2008 at Children's Hospital of Philadelphia, we had policies and procedures in place, and we said everyone's going to pump 8 times a day, and they're going to do it overnight, and we're going to do all these things. And then when we actually collected data on it, people didn't, right? And so we had to go back and do quality improvement work to make sure people were doing the things we wanted them to do from a clinical protocol standpoint. All right, how are we doing? Slow. People are tired. Ooh, no. So here's my challenge then. No, I'm like, this is all seriousness. Here's my challenge. If we actually did this, how many of the world's breastfeeding problems would we solve? I'm working with my group in Botswana right now, okay? Low and middle income countries where there's not great access to breast pumps, right? There's not great access to refrigerators, freezers, anything. We have been working for 5 years in Botswana, COVID interrupted everything, right? To get the time to first milk expression to under 24 hours. When we started in 2000, the time to first milk expression was 5 to 6 days, because that's when the baby started being fed. We finally have it under 24 hours, right? 5 years it took. Oh, back to the slides. Okay, cesarean. I love talking about this study because Peter Hartman was the one who told me I had to do it. So, when we opened our special delivery unit and we started tracking data, and we have a publication called Pump Early, Pump Often, we found that our cesarean birth moms had more milk than our vaginal birth moms. well, that's not what it says in the literature, right? And I said, Peter, can you talk to me about this? And he said, well, Diane, I'm actually not surprised because I know that all of your parents are effectively initiating. Because remember, we have sick babies with moms who are pump dependent, and we're paying close attention to their pumping. We actually roll the pump into the operating room, okay? So 468 dyads, a huge sample. We chart abstracted from the mom's chart, the baby's chart, and we looked at when did the baby come out, when did the placenta come out, and how soon did they initiate. And 90% of our families were initiating within the first 6 hours, okay? Everyone was initiating quickly and effectively because they all were pump dependent and they were all using the initiation computer chip technology, right? Now, I think the more powerful part of this study was also that if they had lactation risk factors, and we looked just at 3 of them, even if they had risk factors, that early frequent pumping, it overrode the lactation risk factors, right? So we need to proactively manage people, right? And so we heard about it from Stuart and Donna, right, in Australia. We heard about it from Paula. What do we do then, like when we get them once they give birth? Do we just be like, oh, let's wait and see? Let's give the baby some time. Maybe he'll latch, maybe he won't. Now, I always want a baby to latch. I always want that baby at the breast. How many times does that happen? That your babies come out, they crawl up, they self-attach, and they do a great job. Does that happen for most of you every day? It doesn't, not any place I've been in the world, right? So we want to prioritize breastfeeding if the baby can suckle effectively. If not, we've got to add on skin to skin. That's not just an hour, but skin to skin, that's all day. I tell my moms who have healthier babies who can actually feed at the breast, be topless for the first 2 weeks at home, right? Have that baby have unlimited access. We want to prioritize adding on pumping, right? If the baby's feeding effectively, great, but if the baby's not feeding effectively, we want to proactively manage that supply. So, case, all right? This mother allowed me to share her story. She has risk factors, right? Before she even gives birth, she has risk factors. She was 41. She was a first-time mom. She has a history of infertility. She did end up going post-dates, had a very long labor. Now, she was going to give birth in America in a hospital that didn't have the initiation technology. Shame on them, right? Shame on them. So I sent her to the hospital with a pump. And so everyone was asking her husband, why do you have that pump? How did you get that pump? Why do you have that pump? And I said to him, because I was out of town when they gave birth, I said, Michael, just keep telling them you're protecting your wife's milk supply. That's all you have to do. So the baby did have a vaginal, came out vaginally. Thank God she had a midwife and a doula. And the baby did go to NICU for meconium aspiration. So this was the baby at home. Mother was both breastfeeding and pumping. It took her till day 10 to 13 to get to full milk supply, okay? So it didn't happen at day 3. It didn't happen at day 5. It didn't happen at day 7, right? So she was really having to work hard to build her milk supply. That's his 6-month-old picture. I couldn't get the 9-month picture. He's actually 10 months now. But he's gotten 100% human milk diet, despite the fact that mom even had to go back to work in a very busy business. True compromise supply. So this would be your breast surgery, your glandular hypoplasia. The thing you're going to do differently is you're going to add on that pumping from day 1. And you're going to talk about a plan for supplementation. So we put a pump at every bedside. When I started Children's Hospital of Philadelphia in 2001, the hospital owned 4 breast pumps. That was it, 4, for a 500-bed hospital. We now own over 400 pumps, over 400, 1 at every bedside. You want to make it easy for people to pump. We want lots of skin to skin around the clock. We want to breastfeed as the baby is able. We need a plan for supplementation. Another polling question would be, do you give PDHM to any parent who requests it? Most hospitals don't. They prioritize it only to a certain group of babies. So someone with a risk factor, they may have to use formula. Maybe they don't want formula. Maybe they're going to look for informally shared milk. If you would have told me 20 years ago I would talk about informally shared milk, I would have told you no. People do it. It's happened since the beginning of time. We want people to know how to do that in the safest way. We've had a waiver in place for 10 years at Children's Hospital of Philadelphia. Parents have to be offered PDHM instead of the informally shared milk. Some will still refuse because of religious reasons, because of personal beliefs, where they want to use their sister's milk or a family member's milk. Post-discharge, okay? Something we haven't really talked about too much yet. What about pediatric primary care? Does anyone work in pediatric primary care that's here today in the room? Just one person, 2 people, right? What happens? What happens when that dyad shows up to the pediatrician appointment at day of life 4 and breastfeeding's not going well? Yes! The first thing is we better supplement your baby because we don't want that baby to lose more weight and get readmitted to the hospital, okay? So this manuscript was part of a guest editorship I did for the American Journal of Maternal Child Nursing. Paula did a guest editorship this summer. I did a guest editorship this summer. We're like twins. It's because we've known each other a really long time. So in this particular article, it really is putting that call to action on the pediatric primary care site to really protect breastfeeding. And we learned from the prior 2 talks, right? People have risk. People don't achieve secretory activation at day 3 to 5. So then if we don't have that pediatric practice being able to proactively manage milk supply, what is going to happen to the lactation journey? It's gonna end, right? And this is a common problem everywhere in the world. And so the figure is actually available publicly in the article, but it really is just focusing people on if breastfeeding has not been going well to date, we need to look at that pediatric site as that stopgap, right? This is our very last chance to save that lactation relationship if no one has started proactively managing them beforehand. We need to do so at this time. It's critical. So, prenatal risk assessment, open and honest conversations with families. I wish this happened every day. We need to talk to people about risk. We need to talk about managing risk. Parents really want to know the science. I get questions about this all the time. Well, do parents really understand what you're telling them? Yes, they want to know the science of their milk. They want to know the physiology of lactation. So always leading your care based on research. You can really adopt and change to have a proactive management strategy. And one of the biggest compliments I got before I came over to Portugal for this conference was teaching a course at CHOP, our breastfeeding resource nurse course. And I had a nurse who said, I've been in labor and delivery and postpartum nurse for 30 years. She's like, I learned more in the past 2 days in your course than I learned in the past 30 years. Again, because it's about leading with science. And I think so many times practitioners are afraid to lead with the science and inform parents because they don't want to hurt their feelings or they don't want to scare them. But we need to lead with science. We need to lead with research. Thank you.
Thank you, Professor Spatz, for your powerful presentation. So now I would like to warmly invite all our speakers to join me on stage for our panel discussion.
I was like, why did I get down? I should have stayed up.
I should have told you.
2, 3, 4. 1, 2, 3, 4. I can be here. Oh, no, no.
Do we have enough? Yeah.
Yep, sorry.
So we received a lot of questions from the audience already, and they are very excited. There was a comment, a great presentation, Donna and Stuart, and thank you really for your insights. But it's also a little critical voice. You suggest that the screening tool works. However, what were the outcomes before implementing that tool? So have you kind of a baseline and can tell about the data? So what does that tool add?
We don't have a QI. The problem with the QI would have been the fact that although we didn't formalise the screening tool, it was developed in a practice that was already supporting breastfeeding in a far more aggressive or proactive way. So what we did was develop this tool based on both the evidence and the clinical experience, and then implemented it and trained all of the staff. The idea about this study was that rather than compare practices, was to implement a model and train everybody in it and then see what the outcome would be. So we have ongoing audits going on, pulling the records and the data. And what we did do was compare the outcomes of those mothers that were screened with our mothers that didn't have risk factors. So it was more about, even with this support, these mothers may still not achieve a full milk production, but they keep feeding at much, much higher rates than the national average. And if we'd killed them by the triple death method. So I hope that answers the question.
Yeah, and that offers also possibilities for other hospitals to test that tool, yes, to assess that baseline.
Yes.
And then...
But the problem is most people don't know what their breastfeeding rates are after discharge. No one is following up. And I think Stuart can talk to the fact that how soon are we seeing people after birth?
So we're seeing them weekly from birth all the way through till 6 weeks, with the option of continuing through to 4 months if the patient chooses. But that also includes the fact that they're getting a phone call at day 3, which is usually the point where they're going home, to allow us to intervene early for those that have had initial breastfeeding issues or have had things like a PPH at the time of birth, which puts them at increased risk.
Yeah, that's an intensive follow-up and really a great proactive lactation support.
Well, the whole design of it is that, as I mentioned to Donna when I first met her, if I see them at 6 weeks, they're either stuffed or they're okay. And so if you wait till 6 weeks till you're intervening on a breastfeeding issue, you've kind of missed the point, right? So the whole idea of why we do it is that we have an early intervention, and we've talked about breastfeeding today, but we also are really proactive in regard to about the adjustment to becoming a parent, about mental health, about the physical recovery after birth. So we don't only just look at breastfeeding, we look at all aspects of care. So we've just highlighted one of the screening tools of many that we do within our clinic.
I think this question or the next question could be either to you, Dr. Prosser, or to you, Professor Spatz. How do you differentiate small breasts from breast hypoplasia? Do you really have an assessment for that?
I mean, they look completely different. So the shape, the fact that there's wide spacing between the breasts is very obvious. And when you palpate them, they don't feel the same.
So I would add that sometimes it's not obvious due to the secondary hyperplasia that we've been terming the poor breast development in the context of obesity or GDM. So I'm now doing a whole lot of ultrasounds again because women, I mean, these have been picked up on the screening tools. They have milk productions to help them understand how much they need to supplement, and then they're invited to come in for a scan. So what happens is those mothers often come, and sometimes really experienced people think that breasts look fine, and they're tense and they look okay. And so the mums come in, and we had one the other day that had about 10 risk factors. I kept swinging my head to Sharon every time we asked a mum the question. But although it's subjective, you can show the mother that she has low glandular tissue. I can point out where it is. And often I can say, does it feel more tense here? And they're like, yeah. Where does it feel full? That's where the small amount of tissue is. So just because they've got big breasts, they might claim they changed in size, but they probably haven't. Doesn't mean they don't have some degree of poor breast development, which we could call secondary hyperplasia. The other thing that's really obvious on the ultrasound is the Dopplers. So I do colour Doppler flow, and they have poor blood flow. Blood flow waveforms that are higher resistance, just like a cord Doppler. That's what it looks like in their breast, which is where we're going with our SGA mums to see if it's actually a blood flow issue, because the blood should double to the breast during pregnancy. And if that's not happening, then those breasts are not going to develop at the same rate.
So just to follow on from that, the ones that we really pick up on, and I know Donna highlighted it, those no breast growth, they're the ones that I'm now referring through to Donna to say, sorry, Donna, for can you do a breast ultrasound? Because they're the ones that we're invariably picking up, the ones that don't have the breast changes during the pregnancy. When Donna ultrasounds them, they have a reduced amount of glandular tissue.
And the feedback's been incredible from the mothers.
The patients love it.
Yeah, they feel like it takes the guilt away. They know they're doing the best they can with what they've got because they've seen what they've got. And really, this is the way we expect to be treated in any other part of medicine or healthcare, that there's a test, a diagnosis, some treatment. And so I think that the mothers really engage with that, and it helps them continue to do their best.
Thank you so much. The next question goes to Professor Paula Meyer. Expression. So many hospitals still recommend hand expression because of colostrum lost in Shield's funnel. Could you comment on that? I think that's directed to mothers of preterm infants.
Yeah. So the whole hand expression issue has, I remember discussing this like 20 years ago. And I think the issue has changed somewhat because in the past, at least, the questions were replacing the breast pump with hand expression because it was thought to be more natural. And I don't think there's any role for that. There's absolutely there is evidence, but it's the opposite way. The idea of using the breast pump, you can absolutely use hand expression before that, after that, if it's something you deem appropriate for that particular mother. But what I would like everybody to think about is that the human infant doesn't hand express. You know, the human infant uses suction. And it's so that if you deprive the infant or the breast of that stimulation, you're really starting off with something that has no basis in the physiology and this intricate interplay between the mother and the baby. Now, does that mean that you've used the pump for 15 minutes and you can hand express? If that's what you want to do and it's successful, there's no reason not to do that. So I think the issue is you don't want to replace the pump with the hand.
Thank you so much. The other question is around antenatal milk expression, and I think that could go to all of you somehow, maybe to Professor Spatz. In the UK, antenatal milk expression is becoming more and more prevalent. Do you teach, advise this for women identified at high risk?
So this is actually one of the reasons Nina, my student, Gentile, wanted to do this research study, was because we were seeing, and we actually looked at the guidelines from the UK that has a whole list of people that they recommend doing antenatal expression for, but when we actually did our integrated review looking at what's been published around the world, there was very little actual concrete objective data. Everything was subjective only. And I think before we consider this, we needed some objective data. And so my view on it is that it may be appropriate for some people to do so, especially if they have risk factors, but we would want to make sure they do that in a way that's based in evidence, that they understand that what they are able to harvest is not going to be large quantities, that after they give birth, they're still going to have frequent and regular breast stimulation and emptying to get to secretory activation. So one of the things that had been subjectively reported in all the 15 studies we reviewed was that it gave parents a sense of confidence, right? It gave them security. They liked knowing that they had milk available to the baby. And we heard those same types of comments from the families who were in our study, where they liked learning about their breasts and how their breasts worked and seeing that they could get milk out and knowing that they had some milk to store for their baby. But I worry the most about the fact that a lot of different people are being told to do it, but not with a good evidence base and a good kind of practical recommendation base of this is how it might benefit you to have some security antenatally, but the
Agora. Quero câmera. Vê lá
Queres
se...
desta câmara? Dá-me o USB deste.
And part of the reason why Donna and her scans have been so useful for our clinical practice is that patients often want to know the answer to why they're having difficulties, and that will allow them to, as Donna alluded to, it takes away some of the stigma and the guilt associated with if they are having difficulties. And as highlighted by the 3 cases I used today, all 3 of them, well, the
We have another interesting question, which maybe goes to the whole panel. One healthcare professional states, I've had a hard time finding any research on the phenomenon of decreasing milk supply after a couple of weeks with sufficient pumping, so more than 6 times a day. It's a problem that we see a lot in the NICU, but don't know how to manage.
I guess my one question would be the pattern of pumping, because I have definitely observed that when people begin to interrupt the nighttime hours of pumping or expressing or feeding, that we'll see dips in their milk supply. And so thinking about that pattern, not just, coming to volume, but then what are they doing to maintain the pattern? That would be one of my questions.
Yeah,
not
the
necessarily
long
answer.
intervals between pump sessions, skipping pumping during the nighttime.
And I would go back to what I had mentioned about standardizing the use of the breast pump. Because if a baby isn't latched onto the breast correctly, you're going to not get good milk transfer and you're not going to continue a milk supply. So that was actually the impetus for my creating the whole pumping pathways at this critical juncture, so that mothers have the right way of using the pump during secretory activation, and again, when the regulatory mechanism changes. But simple things, I mean, we talk about simple things. Are they pressing the breast shield into the breast? Is somebody watching and checking that they're not doing that? Because that occludes the ducts and the milk can't get out. So that would be first step for me, is when I was training my peer counselors, it was always when a mother talks about milk supply, you don't give her any information or recommendation. You sit and you watch your pump. And based on that, and from beginning to end, you watch the pumping before you say you need to pump more frequently, you need to do this, you need to do this. So that would be my recommendation, especially since we'll be doing pumping pathways tomorrow. Sit and watch the mother pump and see what you can detect.
Thank you so much. I think we're running a little out of time. I really want to thank all our dear speakers for this interesting discussion. A warm welcome and applause again.